Greetings from the EULAR 2025 Congress in Barcelona, Spain. My name is Victoria Sadovic, Professor Assistant at the University of Medicine and Pharmacy Nicolae Timișoara, and today we are going to speak about sarcoidosis, a very interesting topic. And my guest is Nathalie Saidenberg Kermanac'h from Avicenne Hospital in France. Thank you for accepting our invitation.
Thank you. Thank you for your interest in this study.
Thank you. And we know that axial sarcoidosis is a topic which is not very much studied. And I know that you presented during EULAR Congress a very interesting research. Could you please walk us through the results of your research?
Yes. First, I would like to explain why we did this study. Bone involvement in sarcoidosis patient is not well understood, and the use of MRI and PET-CT have highly increased the detection of these bone lesions that are not visible on conventional radiography. In fact, 1/3 of PET scan reveal bone involvement, and most often in spine and pelvis. And these findings raise several questions. First, the bone lesions look non-specific on imaging, and it can be difficult to rule out other diagnoses as spondyloarthritis, like infection or cancer. Too many patients with bone involvement have no symptom. So when pain occurs, it can be challenging to determine if the pain is caused by these lesions. And 3, there's no treatment guidelines as the prognosis of this lesion hasn't been studied. So the aim of our study was to assess the prognosis of this axial bone lesion and to explore the association with clinical symptoms. And for that, we conducted a longitudinal study on 48 patients with histological confirmed sarcoidosis and who have bone involvement. All patients underwent at least 2 MRI or PETs, and all images were reviewed with a mean period of 33 months for MRI and 44 for PETs. And our key findings are: 1, highly clinical and radiological prognosis. Most lesions show decrease or complete resolution over time, and no complications were observed. 2, the MRI evolution is very different from that of PET, with negative PET occurring more frequently and faster than MRI. 3, there's no concordance at baseline between pain symptom and imaging. Almost half of patients were asymptomatic, but in contrast, disappearance of pain was significantly associated with the decrease or complete resolution of radiological finding. And 4, we found no concordance between a specific treatment and the evolution of pain, nor the evolution of imaging. And we observed relapse in 7 patients. This is the first study that follow both clinically and radiological outcome in these sarcoidosis patients. And these results suggest a favorable diagnosis and establish correlation between pain evolution and clinical and imaging evolution. And this has direct implication for practice. First, we can optimize imaging strategy. In a patient with bone pain, MRI is the imaging modality of choice, as it provides a better analysis of bone structure, and PET should not be routinely performed due to radiation exposure, but can help in some situations to rule out neoplasia, to confirm active bone lesion before starting a treatment, or if pain persists or returns. And early reimaging should be avoided as abnormalities can persist despite clinical improvement. And the second application is that we could optimize the benefit-risk balance before starting a treatment and consider in some cases that therapeutic abstention may be appropriate, especially in asymptomatic patients. So these results will help us to better manage these patients.
Thank you very much. That's indeed a very interesting study. But speaking about diagnosis of axial sarcoidosis, we know that sometimes it can mimic some other involvements, other axial involvements. So how would you differentiate between axial sarcoidosis and other diseases, like, such as ankylosing spondylitis, for example?
Thank you. This question about differential diagnosis is important, but I think we have to distinguish two situations depending on the presence or the absence of pain. In the presence of pain, the main differential diagnosis is spondyloarthritis, as inflammatory back pain is the predominant symptom in these patients, and it's not very specific. Other signs such sarcoidosis flares in other organs can help us for the diagnosis, but sometimes pain can occur when sarcoidosis is otherwise inactive, making diagnosis challenging due to a possible mismatch between bone involvement activity and overall activity of the disease. And in this situation, MRI is the imaging of choice. It can identify enthesitis or sacroiliitis, which point toward a spondyloarthritis. In contrast, in bone sarcoidosis lesions are nodular or micronodular or patchy with a very different pattern. Sacroiliitis has been reported in 2 previous studies, but these patients also have inflammatory back pain, so they met criteria of spondyloarthritis. And some bone lesions can also mimic sacroiliitis. And recent studies show that there is a clear association between sarcoidosis and spondyloarthritis. So, in sarcoidosis patients with inflammatory back pain, spondyloarthritis should be actively investigated, and finding a sacroiliitis in this case is more indicated associated spondyloarthritis rather than a direct manifestation of sarcoidosis. In asymptomatic patients, the main differential diagnosis is cancer or mycobacterial infection. We did not find any specific MRI or PET pattern for sarcoidosis lesions. However, the absence of abnormality on CT scan and the lack of tissue involvement in MRIs strongly support the diagnosis of bone sarcoidosis in known sarcoidosis patients. And this is important because it can help to decide whether to perform a biopsy, because biopsy could be difficult in lesions that are not visible on CT and sometimes small. However, condensing or lytic lesions are possible, and such lesions warrant a biopsy to ensure accurate diagnosis.
Yeah. Thank you very much for your detailed answer, and thank you very much for accepting coming today and sharing the results of your amazing study. And thank you everyone for watching. We are at EULAR 2025 Congress in Barcelona, and please stay with us for more interviews.
Thank you.